Hello everybody. So today's topic is acute liver failure. We will start with definition. Acute liver failure is defined as acute and chronic liver failure. It is an acute insult manifesting as a jaundice, serum bilirubin more than or equal to 5 mg, coagulopathy, INR more than or equal to 1.5, or prothrombin activity less than 40%, complicated within 4 weeks by clinical ascites or encephalopathy in patient with the previously diagnosed or undiagnosed chronic liver disease or cirrhosis and is associated with the high 28-day mortality. Now, the classification of acute liver failure. So, according to the duration of the onset of jaundice and encephalopathy, it is divided into four types. Like hyperacute liver failure, considering jaundice as a first symptom, hyperacute liver failure described as a patient developing hepatic encephalopathy within 7 days of noting jaundice. Acute liver failure occurs when the patient develops hepatic encephalopathy between 8 and 28 days of noting jaundice. Subacute liver failure describes the hepatic encephalopathy occurring within 5 to 12 weeks of the jaundice, and the chronic liver failure, that means disease duration is a greater than 28 weeks before the onset of encephalopathy. So now the etiology of the liver failure. If you are seeing any patient of liver failure, then first we should find out if there is underlying chronic liver disease is there or not. Now how we will do it? Now how we will come to know about it. So if there is a loss of hepatic mass and the regenerative nodule inducing irregular counters of the liver, this along with the presence of the ascites and the mild splenomegaly is the more suggestive of the cirrhosis. And the indication of the biopsy in the liver failure can also help in knowing the cause of chronic liver failure, which is performed by the transjugular route. And it is done, and it should be done to rule out underlying chronic liver disease, malignancies, and alcoholic liver disease. Now, the etiology of the acute liver failure is very important for prognostication, to decide treatment strategy, and the necessity for the emergency liver transplantation. So, first we'll see the etiology with no indication of the emergency liver transplantation. If the patient has malignant infiltration of the liver, then there is a no indication for the emergency liver transplantation. Or if the patient has acute ischemic injury, if patient has hypoxic hepatitis and other systemic disease like hemophagocytic lymphohistiocytosis, infectious disease like malaria, dengue, rickettsiosis, toxic ingestion like yellow phosphorus. Etiology which forms the possible indication of emergency liver transplantation include drug-induced hepatotoxicity, paracetamol overdose, antituberculous drug isoniazid, antibiotic like nitrofurantoin, ketoconazole, antiepileptics like phenytoin and valproate. Then viral hepatitis, including hepatitis B and hepatitis A virus and hepatitis E virus. The other viral infections like herpes simplex virus type 1, type 2, varicella zoster virus, cytomegalovirus, Epstein-Barr virus, and autoimmune hepatitis. The most uncommon etiologies of acute liver failure is the Budd-Chiari syndrome, Wilson's disease, mushroom poisoning, pregnancy-related ALF, ALF induced by hemihepatectomy, and hypothermic injury from the heat stroke. Now, factors needed to consider in the history. So while taking history, we should always search for an etiology. Like we should ask the patient if there is any use of medication. Like ask very specifically for paracetamol poisoning and paracetamol containing compounds. Then herbal medicine, which are very commonly seen in India, like patient who are on already who are already on the Ayurvedic medicine, uh, they can cause the liver failure or any food supplements, any substance abuse, or history of suicidal attempt and depression, gastrointestinal complaints after mushroom ingestion. Then condition which are permissive for ALF, like pregnancy or any history of traveling in viral hepatic endemic areas like hepatitis B virus or hepatitis C virus, in the recipient of the immunosuppressive or chemotherapy, or history of autoimmune disease. Condition that may impact upon decision in respect to the emergency liver transplantation, like history of chronic liver disease is there or not, active and dependent alcohol or substance abuse, uh, or if there is any history of cancer in the recent past, severe congestive heart disease or respiratory comorbidities, interval between the onset of jaundice and the first sign of hepatic encephalopathy. Then, after finishing with the history part, we should decide about the lab analysis at admission. So we will divide our laboratory analysis into for one for etiology, then the next for toxicology screening in urine and paracetamol levels, serum level. Then the next is the serological screen for virus infections like HBsAg, anti-HBc IgM, delta if positive for HBV, anti-HIV IgM, anti-HEV IgM, anti-HSV IgM, anti-VZV IgM, CMV, HSV, EBV, parvovirus, VZV PCR. Then autoimmune markers in case of any autoimmune hepatitis like ANA, asthma, anti-soluble liver antigen, globulin profile, ANCA, and HLA profile typing. Then the next investigation plan should be to assess the severity of the disease, like PT, INR, factor 5, full coagulation screen, including fibrinogen, liver blood test, including LDH, conjugated, unconjugated bilirubin, creatinine kinase assessment of renal function, urine output. Low urea is the marker of severe liver dysfunction. Creatinine may be difficult to assess in the context of elevated bilirubin. Then ABG and the lactates and arterial. Then consider support management outside the ICU. If the patient is in ICU, then how are we supposed to manage? We should do the routine monitoring, oxygen saturation monitoring, blood pressure monitoring, heart rate, respiratory rate, hourly urine output should be monitored, and the neurological status. Now, the standard care is the glucose infusion, that is 20 to 20%. Glycemic target is should be 140. Then the sodium level should be between 135 to 145. Then stress ulcer prophylaxis. Restrict the clotting factor unless the active bleeding. And acetylcysteine in early stages, even in the non-paracetamol cases. Then some preventive measures like avoid sedatives, avoid hepatotoxic and nephrotoxic drugs. Now, if the patient is in hepatic encephalopathy, then we should transfer this patient to the appropriate level of care at first symptom of mental alteration. Surrounding should be quiet. Head of the end should be elevated. Now the head is in neutral position. Intubate if the patient has, if hepatic encephalopathy is progressing to the more than grade 3. Then should be the low threshold for empirical start of antibiotic if hemodynamic deterioration or increasing encephalopathy with inflammatory phenotypes. In case of evolving hepatic encephalopathy, sedation and intubation prior to the transfer. Ensure volume resuscitation and normalize biochemical variables like sodium, magnesium, phosphorus, and potassium. Now, if we want to transfer this patient to the tertiary care, then what should be the criteria? So we are following this King's College criteria for transfer of the acute liver failure patient. Like paracetamol and hyperacute etiologies, the pH should be less than 7.3. Bicarb should be less than 80. INR should be more than 3 on day 2 and 4 thereafter. Oliguria, elevated creatinine, altered level of consciousness, hypoglycemia, and elevated lactate unresponsive to fluid resuscitation. And if it is a non-paracetamol case, then the pH should be less than 7.3 and bicarb should be less than 18. INR should be more than 1.8. Oliguria, renal failure, and sodium should be less than 130. Encephalopathy, hypoglycemia, or metabolic acidosis. Bilirubin should be more than 3 and the shrinking liver cells. If the patient is fulfilling these criteria, we should transfer the patient. Now there is a Clincy criteria, which includes confusion, coma of hepatic encephalopathy of stage 3 or 4. Then factor 5 should be less than 20% of normal if age is less than 30 years. Factor 5 or factor 5 should be less than 30% if age is more than 30 years. The only definitive criteria contraindicating liver transplantation is the irretrievable liver brain injury. This is normally defined as persistent presence of bilateral non-reactive pupil with no spontaneous ventilation, loss of middle cerebral artery flow, or loss of gray white matter differentiation, and evidence of uncal herniation. Bacteremia presence in 20 to 30% of patients is not a contraindication to the transplantation, providing there is an appropriate response to the positive progressive vasoplegic shock with the rapidly rising vasopressor requirement and peripheral vascular failure would be considered a relative contraindication to proceed. As would severe hemorrhagic pancreatitis and extensive small vessel ischemia. Uncontrolled ARDS or hemorrhagic pancreatitis are also relative contraindication, as would be the finding of markedly low cardiac output state. Then how we should prognosticate this acute liver failure? So there is a R score, which consists of total bilirubin, hepatic encephalopathy grades, PTINR levels, lactate, and the creatinine. Point one for the if total bilirubin is less than 15, hepatic encephalopathy grade is 0, PTINR less than 1.8, lactate less than 1.5, creatinine less than 0.7. Grade point is R score is 2 if bilirubin is 15 to 25, hepatic encephalopathy grade 1 to 2, PTINR 1.8 to 2.5, lactate 1.5 to 2.5, creat 0.7 to 1.5. Then point 3 for total bilirubin more than 25, hepatic encephalopathy grade between 3 and 4, PTINR more than 2.5, lactate more than 2.5, creatinine more than 1.5. So the minimum score is 5 and the maximum score is 50. So if the grade is 1, then the score is 5 to 7. If the score is 8 to 10, then the score grade 2. And if the score is 11 to 5, then the grade 3. Now, the another score which we are using for classification is the Cliff-SOFA score. In that, we are including liver parameters, kidney parameters, cerebral parameters, cognition, the coagulation, that is INR, circulation, that is mean arterial pressure, lungs, PaO to FiO2 ratio, SpO to FiO2 ratio. Liver, if it is 0, then less than 1.2, 1, then the bilirubin should be 1.222. 2, bilirubin should be 2 to 6, and 3, bilirubin should be more than 6 to less than 1 less than 12. 4, bilirubin should be more than or equal to 12. Then the creat should, if score is 0, then the creat should be less than 1.2. If it is 1, then 1.22 less than 2.2. If it is 2, then the more than 2 to less than 3.5. If it is 3, then more than 3.5 to less than 5, and for 4, more than or equal to 5, or renal replacement therapy. Then about hepatic encephalopathy grade 0, no hepatic encephalopathy. 1, grade should be 1. 2 points are given for hepatic encephalopathy grade 2. 3 points for hepatic encephalopathy grade 3, and 4 points for hepatic encephalopathy grade 4. Then the INR is less than 1.1, 1.1 to 1.2. Grade 2, 1.25 to 1.5, grade 3, 1.5 to 2.5, and the grade 4, more than 2.5, a platelet count less than 20,000. Then for MAP should be more than 70, grade 0. If it is less than 70, then grade 1. Dopamine less than or equal to 5, or dobutamine or terlipressin, then grade 2. If dopamine is more than 5, or epinephrine is more than less than or equal to 0.1, or norepinephrine less than or equal to 0.1, then grade 3. Dopamine more than equal to more than 15, or epinephrine more than 0.1, or norepinephrine more than 0.1, then grade 4. Then lungs में there is a PaO to FiO2 ratio. If it is more than 400, then 0. If it is 300 to 400, then 1. If it is 200 to 300, then 2. If it is 100 to 200, then 3. And if it is less than 100, then 4. If a Cliff SOFA score is more than 60, then 3-month mortality is more than 3%. If Cliff SOFA score is less than or equal to 45, then 3-month mortality is less than 2%. Then the next score is model for end stage liver disease, that is MEL score, and it is 3.78 into serum bilirubin plus 11.20 into INR plus 9.57 into serum creat plus 6.43. If score is more than or equal to 40, then 90% mortality is 71.3. If score is between 30 to 39, then 90% mortality is 52. If score is between 20 to 29, then 90% mortality is 19.6. If score is between 19 to 10 to 19, then 90% mortality is 6%. And if the score is less than or equal to 9, then 90% mortality is 1.9. Then the next score is acute liver failure early dynamic score, that is Alfred score. In that components are hepatic encephalopathy grade more than or equal to 2, INR more than or equal to 5, arterial ammonia more than or equal to 123, bilirubin more than or equal to 40. Then we have to assess the score on day score on admission and score on day 3. And if score is between 0 to 1, then it is a low score, mortality is 0 to 5.6. If it is a moderate score, then the score is 2 to 3 and the mortality is 19 to 21%. If high score, then the score is 4, mortality 67%. Score 5, mortality 84%. Score 6, mortality 100%. Then the next scoring system is the child book score. In that, the parameters included are ascites, encephalopathy, total bilirubin, albumin, and the prothrombin type. And points given are 1 point if ascites is none, 2 point if ascites is slight, 3 point if there is a moderate to severe ascites, encephalopathy 1 point if none, if encephalopathy is none, slight to 2 point slight to moderate, and 3 point moderate to severe. Total bilirubin 1 point less than 2, 2.2 to 3, 3 point more than 3. Albumin more than 3.5, 2 points 2.8 to 3.5, 3 point less than 2.8. Prothrombin time 1.123, 2.426, and more than 6, 3 point. Child book score 5 to 6 point at least the severe liver disease. Child book score child book B if 7 to 9 points, then the moderately severe liver disease. Child book C if 10 to 15, more severe liver disease. Then according to the guidelines, ARC score is the very good prognostic score for severity assessment and has been adequately validated. It has been proven to be superior to the mailed and mailed sodium criteria. Clip SOFA and SOFA score for patient with the acute and chronic liver failure. So we'll see how can we utilize this R score. The patient is diagnosed with acute or chronic liver failure, and if it is acute insult, then we should first identify what is the cause, and then we should direct our therapeutic options according to that. If the R score is less than 10, then we should follow the supportive management, and if it is not less than 10, then we should give the organ support. And if the R score is more than 11, and if there is a no organ involvement, then straight away we can take the patient for liver transplantation. And if the R score is more than 11 and also there is a organ involvement, then first we should give the supportive treatment to that for that organ, and also the bridge therapy. If patient is improving, then we should take the patient for liver transplant, and if the patient is not improving, then we should continue with the supportive management, and we should explain the relative about the poor prognosis. Then now we'll see about now till now we have seen how are we supposed to manage the patient in patient if he's a candidate for the liver transplant, and now we will see the organ specific management. So the most patient presenting to the ALF or severe ALF develop systemic vasodilation and the reduce effective central volume Blood volume. So hyperlactemia is the consequences of the hypoperfusion. Hypoperfusion can be corrected with the fluid pools. So the general critical literature supports the use of the prescribed over quality. So following adequate volume loading, the persistent hypotension requires the treatment with the vasopressin. So the initial pressure recommended would be norepinephrine at starting dose of 0.5 microgram per kg per minute. Additional low dose of the vasopressin 1 to 2 units per hour should be considered if norepinephrine requirement is more than 0.2 to zero point 0.3 microgram per kg per minute. Hydrocortisone therapy does not reduce the mortality but decrease the vasopressin requirement. Excess fluid and the persistent positive fluid balance is associated with the higher mortality. Elevated venous pressure can be associated with the increased tissue edema and the greater impairment of the microcirculatory fluid. Elevated right-sided cardiac pressure may be detrimental to the liver venous flow and hence liver function and regurgitation, gut integrity, and the renal function. Therefore, volume overload should be avoided as much as volume depletion. Now, the respiratory management. Invasive airway management is required in case of the high-grade hepatic encephalopathy to ensure the airway protection. Also, in case of hypoxia and the respiratory failure. Non-invasive ventilatory support should be avoided in those patients at risk of hepatic encephalopathy because of high risk of neurosurgical deterioration, aspiration, and poor compliance. Sedation is normally undertaken with a short-acting opioid and propofol. Propofol has the potential to decrease the blood pressure if the patient is not volume restricted. So resuscitate patient properly before giving propofol. It decreases the cerebral metabolic rate for oxygen as well as it has the anticonvulsant properties. Ventilatory setting should be protected. Low tidal volume and appropriate level of the PEEP should be utilized. Hypercarbia and hypocarbia should be avoided. CO2 target should be between 34 to 40. So the tidal volume should be maintained at 6 ml per kg of ideal body weight with maximum of 8. High level of PEEP that is more than 12 should be monitored regarding transmitted pressure risk with the middle cerebral artery block. The balance of hypoxia, hypercarbia, and risk of increased ICP must be individualized at the bedside. In some patients with the hypoxic hepatitis, there is evidence of hepatorenal syndrome, and this should be excluded with the bubble ECG. In few cases, there may be evidence of toxic liver syndrome with the increased lung water and ARDS. Assessment of the lung water may facilitate optimal management of this patient. In some patients with the significant ascites, the presence of intra-abdominal hypertension may result in significant hypoxia and may be treated with limited volume paracentesis. Now, the gastrointestinal management. Oral nutrition should be encouraged in patients with the acute liver injury. Progressive hepatic encephalopathy and anorexia is likely to result in decreased calorie intake. Consideration may be given to the insertion of nasogastric tube to facilitate enteral feeding. The potential risk includes causing bleeding during placement and the large gastric residue and the microaspiration if itchy progress. Calorie and protein requirements are as per critically ill population of other etiologies. Ammonia monitoring should be useful during enteral feeding to ensure there is no associated increase. Failure of gastric emptying may be addressed through placement of post-pyloric feeding tube, but small bowel failure is more difficult to diagnose. Development of ileus and the risk of non-occlusive ischemia may be associated with the gut bacterial translocation. The decision to introduce TPN should be based on baseline nutritional status and duration of the low-calorie intake. Recent studies have not demonstrated any benefit to institute TPN prior to the day 5 to 7 of post-critical care presentation. All patients with the ALF have increased resting energy expenditure, which is similar to the critically ill patient. Early introduction of enteral feeding will minimize the loss of muscle mass and reduce the risk of gastrointestinal hemorrhage. In some patients with the significant mitochondrial dysfunction, lipid loads will not metabolize and may accumulate compounding liver injury. This may especially be case when propofol is utilized in high doses as sedative agent. Therefore, monitoring lipid profile along with the creatinine kinase is required targeting serum triglycerides. Patient with the ALF will release the free fatty acid into splanchnic circulation. There will be the profound alteration in circulating amino acids. which is characterized by the increased tryptophan and its metabolite, aromatic sulfur-containing amino acid, and reduced branch-chain amino acids, leucine, isoleucine, and valine. So the excessive infusion of amino acid may aggravate the hyperammonemia and may and that characterize and that is the characteristic of the ALF and precipitate cerebral edema and intracranial pressure. So the proton pump inhibitors are normally administered, although the evidence base for their use is based on the risk factors of organ failure and coagulopathy. However, this should be balanced against the risk of ventilator-associated pneumonia and the C. diff infection. PPI should normally be discontinued when enteral nutrition is started. ALF is frequently associated with the electrolyte and metabolic disturbances, which are more common in patients with the hyperacute ALF, especially when associated with the AKI. Hypoglycemia is the well-recognized complication of ALF and it is a multifactorial in the pathogenesis. Increased hepatic extraction of the glucose, increased hepatic glycolysis, and impaired gluconeogenesis with the failure of compensatory renal gluconeogenesis. Now, how to treat this hypoglycemia? The frequent monitoring of the blood glucose is required in patients with ALF, especially hyperacute cases. Rapid policies of the concentrated glucose may induce the large osmotic shift in the intravascular and cerebral compound and should be avoided, but may be necessary to treat critical hypoglycemia. Now, this hypoglycemia is the predictive of the developing acute kidney injury and predictive of high mortality. So, the hypoglycemia can exacerbate raised ICP and should be avoided. Tight glycemic control with the infusion of insulin may reduce the mortality in critically ill patient with target blood glucose between 150 to 180. Hyponatremia is relatively common in patients with acute liver failure, and there is a correlation between the serum sodium and the ICP. So the infusion of hypertonic saline to maintain the serum sodium between the 145 to 155 compared to the standard care resulted into the reduced ICP and less requirement of the bolus therapy for sustained episode of raised ICP. A decrease of vasopressor requirement was also observed during first 36 hours of infusion. Hyponatremia should be avoided. Serum sodium above 150 may be associated with cell damage and should be avoided. Therefore, fluid resuscitation and hypertonic saline infusion should be targeted to maintain sodium at 140 to 150. Rapid change in sodium level should also be avoided and correction should be corrected to the rate of drop, which should not exceed 10 ml per liter per 24 hours. The observed benefit of NAC in the ALF have been attributed to the effect of sodium. Acidosis is due to increased circulating lactate and the reduced bicarbonate are common feature in patients with the hyperacute and acute liver failure. Acidosis is less common in the subacute ALF syndrome due to alkalinizing effect of hypoalbuminemia. Both acidosis and increased lactate are the prognostic marker in the paracetamol-induced ALF. Alteration in the serum phosphate, magnesium, calcium, potassium are commonly observed and should be monitored and corrected as clinically appropriate. Hypophosphatemia is the favorable prognostic sign because it is associated with the liver generation. So the careful replacement therapy is required, however, to avoid the potentially serious organ dysfunction associated with hypophosphatemia. Now, acute kidney injury and renal replacement therapy. Now, the causes of acute kidney injury and liver failure is hepatorenal syndrome, hypovolemia-induced liver failure, parenchymal liver disease, and drug-induced renal disease. So, hepatorenal syndrome is diagnosed on the basis of serum creatinine concentration of more than 1.5, which is not reduced, with administration of albumin and 2 days off and diuretics, along with the absence of current and the recent treatment with the potentially nephrotoxic drug. The absence of shock and the absence of finding suggestive of parenchymal renal disease, that is urinary excretion of more than 500 mg of protein per day, more than 50 red cells in a high power field, and abnormal kidneys on ultrasound. The syndrome is classified into two types. Type 1 is characterized by the doubling of serum creatinine level to more than 2.5 in less than 2 weeks. And type 2 is characterized by stable or less rapid progressive course than in type. The parenchymal renal disease should be suspected as a cause of renal failure when proteinuria or hematuria or both are present. Proteinuria should be more than 500 mg protein per day. Hematuria should be more than 50 red cells per high power feed. And ideally should be confirmed by renal biopsy if this procedure is not contraindicated. The differential diagnosis between acute tubular necrosis and hepatorenal syndrome remains the difficult issue. The presence of renal tubular epithelial cell in the urinary sodium favors the diagnosis of acute tubular necrosis. Continuous mode of RRT are preferred to the intermittent dialysis. These therapies avoid the large metabolic and hemodynamic fluctuation associated with the intermittent dialysis, which could precipitate reached ICP. Lactate-free zone accelerate the correction of the acidosis. Anticoagulation for dialysis is the subject of much debate. Patient with the cirrhosis will tolerate citrate anticoagulation, and patient with the acute hyperacute ALF may be less able to metabolize the citrate. If citrate is used in the context of ALF, then the close monitoring of the total calcium compared to the ionized calcium is required. Then coagulation, monitoring, and the management. Disordered coagulation is the essential diagnostic component of the ALF. Rapid changes in the PT or INR are characteristic and of significant prognostic value. Thrombocytopenia, circulating pro and the procoagulant protein, and the increased plasminogen activator inhibitor are all commonly reported into the ALF. The prophylactic correction of the coagulation of platelets is not necessary. It may instead adversely affect the prognostication, as well as there is an increased chance of thrombosis or transfusion-related acute lung injury in patients with the ALF. The hemoglobin target should be more than 7. There are two situations that requires the active management of the coagulation of the platelet. First, the insertion of the ICP monitors require the infusion of fresh frozen plasma, cryoprecipitate platelet, depending on the initial assessment of the coagulation. Others have suggested the prophylactic recombinant factor 7A prior to the insertion of the ICP monitoring. But there is no evidence of decreased mortality and the potential significant risk of thrombosis. Secondly, significant active hemorrhage necessitate the correction of coagulation, thrombocytopenia, in addition to the identification and the local measures to deal with the source of. Now the brain in ALS. Now what are the neurological manifestations? So hepatic encephalopathy is the essential manifestation of ALS, which is characterized by the decreasing level of consciousness and the altered neurotransmissions. So the diagnosis of HE is the clinical and requires the exclusion of other causes of neurological disturbance. There is hypoglycemia, hypercapnia, non-convulsive seizure, stroke, encephalitis, effect of sedatives, and the other causes. So one characteristic manifestation of the ALF is the development of clinically significant brain edema and intracranial hypertension. This can manifest as a result of arterial hypertension, bradycardia, mydriasis in patients who have progressed to grade 3, grade 4 coma. Now there is a West-Haven criteria for grading of hepatic encephalopathy. So according to this, if the patient has grade 1 hepatic encephalopathy, if there is any intention, inattention, euphoria, anxiety, altered sleep pattern, or decreased attention span. Grade 2, if a patient is lethargic, behavioral symptoms, time disorientation, hysterexis, personality disorders, and hyperactive deep tendon reflex. Grade 3, somnolence or semi-stupor, responsive to stimuli, time and place disorientation, hysterexis, and hyperactive DTI. And the grade 4 if the patient is in coma. Now, how we should manage this hepatic encephalopathy? If there are low level of hepatic encephalopathy, then the routine clinical, mainly neurological examination is mandatory in order to detect early signs of hepatic encephalopathy and progression to the high grade of hepatic encephalopathy. Patients should be managed into quiet environment with regular monitoring and management of the other parameters with special attention directed to serum sodium, Although ammonia reducing strategies may be benefit, the role of conventional treatment for hepatic encephalopathy, that is lactulose and rifaximin, have no evidence base in acute liver failure. Lactulose may be associated with the increased risk of IDS and bowel dilatation. So, management of the patient with the altered GCs. Once the patient progressed to the grade 3, the general practice at transplantation center for intubation and mechanical ventilation. So, the measures that protect the airway and prevent the aspiration provide safer respiratory care. Grade 3 coma in the context of ALF and its management is not identify the hepatic flaps, but the development of the marked agitation, the frequent aggression with decreased GCS. Progression to the grade 4 is associated with the marked reduction of the GCS. So, ventilatory management specifically related to the cerebral protection include minimizing the risk of pulmonary barotrauma, aiming for partial pressure of carbon dioxide between 34 to 42, and use of propofol as the sedative agent. This may protect from the intracranial hypertension and reduce the risk of seizure. A short-acting opiate should be added to provide the adequate analgesia. In case of concern of seizure activity, EEG monitoring should be undertaken and antiepileptic drug should be administered. However, the prophylactic use of the antiepileptic drug is not warranted. Phenytoin has traditionally been the medication of choice. However, agents without the risk of hepatotoxicity and more easily achieve therapeutic level, such as levetiracetam and lacosamide, are now more frequently utilized. Now, intracranial hypertension. Brain edema that causes the intracranial hypertension is classically described complication of hepatic encephalopathy. ICH affects one-third of cases which progress to the grade 3 or 4. Patients at risk of the ICH are those with acute or hyperacute or acute phenol. Shorter jaundice and encephalopathy interval, younger age, renal impairment associated with the increased ammonia and inflammatory phenotype, increased need of inotropic support, persistent elevation of the arterial ammonia level, especially following initial management, also indicate the increased risk of ICH, while decreasing the values represents the lower risk. The physical sign defined at clinical examination includes pupillary dilatation, fixed sluggish response to light, sustained hypertension, which are not sensitive enough to the predictive changes in the eyes. Brain imaging may be reliable, but CT scan are relatively insensitive to acute ICH, and moving patient with the severe hepatic encephalopathy can lead to surges of ICH. For this reason, scans are not recommended for monitoring brain edema and are reserved for diagnosing intracranial bleeding, cerebral herniation with absent perfusion. ICP monitoring provides the gold standard for measurement and monitoring of ICP, hence management of pressure surges. Its use not seen modify patient's outcome and is associated with the clinical risk. Bleeding within cranium combined with the brain edema can lead to the significant morbidity and mortality. Therefore, placement of ICP device remains the matter of intense debate with their use reserved for patients at high risk of ICH. Several non-invasive techniques have been proposed to estimate ICP, that is, changes in the cerebral blood flow, reflecting ischemia, vasodilation of the cerebral circulation and resistance to the flow. With increased ICP can be assessed using middle cerebral artery Doppler. An increase in cerebral blood flow usually precedes the rise in the ICP. And measurement of optic nerve depth is also representative of ICP according to the recent assessment. So, if there is a raised ICP, then general management care should be elevation of head at 30°, avoidance of fever, hypoglycemia or hyperglycemia. Serum sodium level should be between 140 to 145. Patients who are monitored for ICP pressure should be maintained below 20 to 25. The difference between the MAP and the ICP should be remain above 15 mmHg. Sustained surges in the ICP, that is more than 25 mmHg, and development of the clinical signs should be treated by bolus of hypertonic saline or intravenous mannitol given over 20 minutes in addition to ensuring optimal sedation. In a resistant scenario, a short period of hyperventilation should be required, reducing arterial PCO2 to 25 to 30. Steroids are not recommended. It is essential that serum osmolality is maintained below 320 and RRT may frequently be required to facilitate this. In situation where the patient has cerebral hyperemia and signs of ICH persist despite mannitol and hypertonic saline, a bolus of intravenous indomethacin may be considered. 0.5 mg per kg. L-ornithine, L-arginine has not shown any beneficial effect. Mild hypothermia may be effective for uncontrolled ICH, but other critical care literature reports that although hypothermia decreases ICP, there is no beneficial effect on mortality. Hepatectomy is the theoretical possibility as bridging procedure to the liver transplant for those patients with the devastating and medically uncontrolled ICH in whom there is a perceived to be no chance of spontaneous survival. Now, the last part is sepsis. Patient with the ALF, they are at increased risk of developing infection, sepsis, septicemia. Infectious complications were the leading cause of death in ALF, although recent data suggests bacteremia is not independently predictive of the mortality. Severe untreated infection may preclude liver transplantation or complicate the post-operative course. Patients with the ALF have multiple immunological alteration and increased requirement for invasive organ support or monitoring, which contributes to colonization with multi-drug resistance bacteria and the development of nosocomial sepsis. Bacterial infection have been documented in 60 to 80% of patients, most commonly pneumonia, which is occurring into the 50% of patients, urinary tract infection in 22%, intravenous catheter-induced bacteremia 12%, spontaneous bacteremia 16%, gram-negative enteric bacilli, gram-positive cocci are most frequently isolated. Absolute attention to the hand washing and care of extraneous monitoring devices such as urinary catheter, venous and arterial cannula, appropriate bronchial toilet are essential. Strict asepsis should be utilized when lines are managed. Now the diagnosis of infection. Admission and the frequent screening of the blood, urine, appropriate sample for culture should be performed as clinically indicated. Admission, hepatic encephalopathy and SIRS score more than 2 are significant predictor of the bacteremia, and deterioration of the mental status, unexplained fever, leukocytosis may present the onset of infection, particularly in patients with paracetamol toxicity. Deterioration in the hepatic coma grade after initial improvement, pyrexia unresponsive to antibiotic, established renal failure, marked elevation in the WBC count should prompt aggressive investigation for fungal, bacterial, and viral infection. This is especially important in patients already on broad spectrum antibiotics. Use of biomarker for fungal infection should be utilized while recognizing their high false positive rate, but the low risk of false negative risk. Treatment versus prophylaxis and infection control standard. Empirical broad spectrum antibiotics should be administered to ALF, to patients with the ALF who have signs of SIRS, refractory hypotension, unexplained progression to the high grade of H. Selective bowel decontamination using non-absorbable antibiotic and parenteral antibiotic also do not impact survival. An association of infection and SIRS with the progression to the deeper stage of HA have been reported, and reduction of the infection in the SIRS may have an impact on ICP. So there is no sufficient data to support generalized antibiotic prophylaxis practice in ALF. Empirical antibiotics are recommended for patients listed for super urgent liver transplantation, since the development of infection and sepsis may prompt delisting. Decisions surrounding antimicrobial choice should be based on knowledge of local microbiological data. SIRS appear to be involved in the worsening of itching, reduces chances of transplantation, and confer poor prognosis independent of infection. Similarly, the development of SIRS precedes the development of organ failure, and increased SIRS score was associated with increased SOFA score and risk of mortality. There is association between the infection and the SIRS. Arterial lactate level correlate with the SOFA score, number of SIRS component, and inflammation also plays synergistic role in pathogenesis of high grade of HE and the raised ICP because of its effect on cerebral blood flow and activation of brain inflammation. Inflammatory marker, arterial ammonia, and cerebral blood flow were higher in the patient with the poor prognosis, and TNF alpha level correlates with the cerebral growth.